So with that, I would like to introduce our keynote speaker. We're so glad she was able to make it all the way from Finland, given all the flight issues and travel bumps. So we're really glad to have her here today. Dr. Riley Rainenko received her MD and PhD degrees and training for a specialist degree in radiology and in neuroradiology at the University of Turku in Finland. After working at the university hospitals in Turku and Helsinki in Finland, she worked at the University of Michigan. In 1994, she moved to Sweden as professor of neuroradiology at Uppsala University. After her retirement, she continues to work on additional scientific projects, diving into diagnostic utility of new methods and describing normal brain and spine structures in different age groups have been primary areas of her research, as well as in hereditary neurologic diseases in children and adults. She has also been chief of neuroradiological unit at the Meilahti Hospital, Helsinki University Hospital, Finland, and at the Uppsala University Hospital, Sweden. Thank you so much, Dr. Rainenko, for making the long trip here. Look forward to hearing your talk.
Good morning, everybody. Nice to see that there are persons here. Yeah. So I will talk about the radiological changes and clinical cause of LMNB1 related autosomal dominant leukodystrophy. I make a small change in the title, and it is provocative, but I like to have more discussions about the name of the disease. If we use literature to see the history of this disease, it is very difficult because this disease has been so many different names. And Eldridge and co-workers who first described the disease in 1984, they used the name hereditary leukodystrophy mimicking chronic progressive multiple sclerosis. It is quite the awful name. And then, I don't know who started that, but it was called shortly Autosomal Dominant Leukodystrophy, ADLD, very nice name. It was also taken in the OMIM catalog. But the problem is that there are also many other autosomal dominant leukodystrophies, not only these diseases. Our group used then name adult onset ADLD with autonomic symptoms, very long name, and now we know that all those patients had not autonomic symptoms. And the Italian group has used the name autosomal dominant adult onset demyelinating leukodystrophy. Can you imagine something even longer? So my suggestion is to call this disease LMNB1 related ADLD. It is quite short and it's defined which we are talking about. And then about the genetics. There are two reasons: duplication of the LMNB1 gene or deletion upstream of LMNB1 gene. And the first group, it is the big group. We know about 30 families, and with deletion 5 or 6 families. That duplication group is what Kasar called canonical ADLD. And I start with talking about that type of ADLD first. And what are the clinical symptoms? The clinical onset is in the 5th or the 6th decade. It means from the age 40 to near 60 years. Symptoms comes first from the autonomic nervous system in almost all cases, and thereafter they get also pyramidal and cerebellar symptoms. The autonomic symptoms, they are many. There can be different combinations, but they all have bladder dysfunction. And the most usual type is mixture region urgency. Bowel disturbances are also very common. Constipation is the most usual. Impotence, postural hypertension, and then maybe about 10% have also dry skin, inability to sweat, and heat intolerance. Heat intolerance includes, for instance, that if they have fever, the symptoms became worse, but they recover. Gait and coordination difficulties are the next group symptoms, but there are some patients who have gait as the first symptom. Cerebellar ataxia and tremor, they are common, and then at later stages also motor symptoms. Spasticity and weakness, spasticity is more common, and those symptoms start from the legs, spread upwards to the arms, and also in the throat and oral muscles. And in the advanced states, those patients have difficulties in swallowing and speeching. We don't know very much about cognitive skills in these patients. We know that in advanced stages, some may have even dementia, and they have cognitive problems, not in the beginning, but later in the disease. But there, or if it is, but I don't know, a large systematical study about the cognitive skills in these patients. And then disease duration. In our study group of 25 patients, the median survival time from symptom onset to death was 18 years. Some had the duration more than 20 years. And I start with Darting's MRI findings in the brain. These are typical images of ADLD patients. This patient has symptom onset 6 years earlier. And even those who don't know so much of radiology can see that there are very much white areas in the brain. Those white or almost white areas, they all are pathological. And if we look at the images and see how large areas are affected, there is a discrepancy with clinical features which are not so severe. These images show the most usual symptoms. You can see those large signal intensity changes. They can see in T2-weighted images, which can be taken from FLAIR sequence, like these axial images of its Spinal sequence in this coronal slice. Large parts of the white cerebral white matter have been involved, and it is typical to see changes here in the middle cerebellar peduncles. We can see such involvements also in some other diseases, but they are totally different diseases clinically, so this is not the differential diagnostic problem. And if you look at area here around the ventricles, you can see that here around the ventricles goes a rim in which the signal intensity is not as pathologic as here. And we can see those ribs here, and we can see those here. This is a characteristic finding. I don't know any other diseases with that kind of rates. Always when we talk about MRI, we must remember that changes in all diseases are different if we use different sequences. Therefore, we should always mention how we have taken those images. The two-weighted images are the most useful, and there are two most common ways to take the two-weighted images on the brain. They are Spinal images and FLAIR images. Spinal sequence is the classical. We have had it from the 80s. And the FLAIR sequence is a newer one. And now quite many centra have stopped taking spinal images, the two-weighted spinal images, and replaced them with the FLAIR images. It works in most patients, but unfortunately not in patients with suggested ADLD. In those, we must always use both sequences. And why? If you look at this spinal image, you can see there's affected area and less affected ribs around the ventricles. And in the earlier image, we can see those rims also in a FLAIR image. But if you look at this FLAIR image, this rim is the lightest. So we can't make a diagnosis if we have only these images. And therefore, to diagnose or exclude ADLD, we should use combination of both sequences. And FLAIR sequences can be useful in very mild changes, which can be later to see with this sequence. But in typical cases and most advanced cases, FLAIR sequence is not ideal. Then I present the results of our study in 25 patients. It was a follow-up study up to 20 years. Some had been followed up in an even longer time. 23 of them undergone MRI of the brain. And here we can see a line for every patient. And those who had also clinical symptoms had this black line, and those who had no clinical symptoms had green lines. And here we can see that those youngest patients, they are asymptomatic, but all those subjects had abnormalities in MR images. So MR images are much more sensitive than clinical symptoms. And this group is very interesting. We can see that 3 of those 4 patients developed clinical symptoms, not the fourth one, and the reason was that he died accidentally here. In this follow-up study, we can see how this disease progresses. And the first symptoms were seen here in the uppermost part of the pyramidal tract, just under the motor cortex. And then they spread downwards along pyramidal tracts, first through the internal capsules, then through the brainstem, in the pons here only in the left side, and then in the medulla oblongata in the pyramids. After After the first affection of the pyramidal tract, we can see changes here in the middle cerebellar peduncles, also in the upper cerebellar peduncles, but they are most prominent here. We can see such involvement in a few other diseases, but they are totally different clinically. So this is not a differential diagnostic problem. It's Dr. Gerd. Then there's a pathological changes. They became larger and most of the white matter is affected here in the upper part of the cerebrum, typical dark rims here again. And then the changes continued along the occipital horns in the occipital lobes and at least along the temporal horns into the temporal lobes. To demonstrate the progression of the disease, I'm sorry. We created a grading system 1 to 5 for those patients. Here we have examples of 2 patients. The first one has been examined at the grade 1, 2, and 3, and the second one in the grades 3, 4, and 5. And first involvement of the pyramidal tract, then progress in the vicinity of those changes and in the middle cerebellar peduncles, and then general progress. And in those last 2 grades, 4 and 5, we see that ventricles become larger, also sulci became larger, which means that the brain lose a volume. Then we compared progression in MRI images to patients' disability. We used Kurzges's expert in disability status score, EDSS, which has been created for MS patients, but it worked very well also for these patients. These yellow areas are those years under which the patients develop clinical symptoms. And first we have radiological pathology here, then clinical symptoms. We can see that MRI grades grows, and we can see the same trend here in disability, but all just happens later. Then I talk about the changes in the spinal cord. Many people think that leukodystrophies are diseases of the brain, but there are some leukodystrophies which also affect spinal cord. And LMNB1 related ADLD is one of them. When we started this study, we also thought that it is a brain disease, and we only examined brains. But then I saw that all those patients had in the brain images, we can see there also the uppermost part of the spinal cord. The spinal cords were very thin. And then our PhD student said that those first symptoms, they are similar in those patients who have myelopathy. We need a PhD student for that. And then we added examination of the spinal cord in our study program. 14 subjects underwent at least one spinal MRI. The first examination varied from 34 to 70 years. 2 of those patients were asymptomatic and 12 had symptomatic, and they had all degrees of severity from mild to severe. A follow-up was made in 9 subjects. Duration of follow-up varied from 1 to 10 years, and median was 5 years. And here some images of the spinal cord. I suppose you are not used so much spinal MRI, and the images can be a little strange. So this is a transversal slit. This is the vertebra, fat around the dural sac. This white area is cerebrospinal fluid, and this is the spinal cord. This is a healthy control, and in healthy people, the spinal cord is quite homogeneous. There is white matter and gray matter also in the spinal cord. But spinal cord is a technically difficult area for MRI because there are so much disturbances in the magnetic field. And most often we can't analyze the parts of the spinal cord. It is homogeneous. But how was it with ADLD patients? First, one could see that spinal cord was reduced in size. This was the most patient with most severe symptoms. So this is the minimal size of the spinal cord. And here we can see white matter, and these dark areas are gray matter. The clue is that if we can see white matter and gray matter separately in the normal persons, white matter is darker than gray matter, and here it is opposite situation, which shows that white matter here is sick. We made also measurements of the diameters of the spinal cord and cross-sectional areas. We didn't have own controls in this study, but we used the normal values from a German material. And we could see that findings were abnormal in all of our patients. All had spinal cord atrophy, more or less, and all had also T2 hyperintensities in the white matter. And those patients had also changes in the brain. Entire white matter was involved in 12 or 14 subjects. One of them was asymptomatic. Here again, a good example, very thin spinal cord. The medulla oblongata is also very thin. And then a transverse slit showing a pathological white matter. In 2 patients, the entire white matter was not affected, but anyway, there were abnormal areas. And both of those 2 subjects were asymptomatic. Oh, sorry, one of those 2 subjects was asymptomatic. Then I saw examples of two subjects. In the first examination, the age was 34 years, no clinical symptoms, thin spinal cord, and white matter is pathological, but it was inhomogeneously hyperintense. 6 years later, the whole white matter was hyperintense, and the volume of the spinal cord was even smaller. And here the brain slices are the same types than in the spinal cord examinations. During the first examination, we can see small pathologic areas here, but they are very small, and signal intensity change is also quite mild. 6 years later, we can see those changes much better. And here, an older patient, 56 years old, and in this case, we can see that the spinal cord is inhomogeneous, even in this sagittal image, and we can see that white matter is here. Most of the white matter is pathologic, but a little the image is from this level, and from this level we can see that there are small hyperintensities in the spinal cord, but most looks quite normal. This patient had symptoms, autonomic symptoms, and also weakness in the legs. And when we looked at his brain, you can see that there are quite huge signal intensity changes. We're going to get. And then some words about the clinical relations of the clinical findings and MRI. In the follow-up, we could not see no clear progress in 5 cases. But if the spinal cord is very atrophic, and if the whole white matter is pathologic, even in the first examinations, it is impossible to see some progress. And clinical progress was shown in 4 of them. Progress of atrophy was seen in 2 subjects. Both had also clinical progress. Progress both in atrophy and T2 hyperinsensitivity seen in 1 subject with clinical progress. And then in 1 subject, we saw only progress of hyperintensity, and that patient subject was asymptomatic in all examinations. 2 asymptomatic subjects, they both had severe spinal cord changes, but very mild brain changes. So the symptoms in the patients, they come both from the brain and from the spinal cord. Then a summary of those spinal cord examinations. All patients having LMNB1 related ADLD caused by a duplication in the gene, the spinal cord is severely affected. Even asymptomatic subjects with a genetic linkage to the disease can have severe spinal cord changes, but very mild brain changes. And the earliest symptoms resemble those in myelopathy. Our hypothesis is that the first affected part of the CNS in LMNB1 related autosomal dominant leukodystrophy may be the spinal cord. Then I will talk about this other type of gene defect, deletion upstream of LMNB1. Those patients present clinical symptoms a little earlier than patients with a duplication. I have not seen MR changes in patients with duplication before the age of 40 years, but it happens in deletion patients. Autonomic symptoms are lacking. Some can develop them later, but most have not at all. And which are the typical symptoms in deletion subjects? They have progressive oral motor dysfunction. Lower and upper limb spasticity and weakness can be seen, cerebellar dysfunction, ataxia, and prominent cognitive impairment. So those all are different things than in patients with duplications. I have seen images of 4 such patients. In one of them, the changes were similar to duplication in the duplication patients, but in 2 of them, there were no changes in the middle cerebellar peduncles or lower brainstem, but upper part of the brain was the same as in duplication patients. And then we had that big surprise. One of the patients who had changes which I don't have seen them any other patients. Here we can see area of pyramidal tract and vicinity. And if we use FLAIR sequence, we can see that the middle part of this pathological area has a very high fluid content. And those changes continue in the pyramidal tract through the internal capsules and even in the mesencephalon, but not downwards after that. So this is the patient that if someone has shown these images to me and asked, can this be ADLD? I had said, no, it is not. But all is possible. Now I could make it myself. Then a summary of differences on brain MRI between patients with duplication and deletion. Cerebral atrophy is not a prominent feature in duplication patients. They can show that in 2 highest grade, but not earlier. But it is quite common in deletion patients. Hyperintensity in the middle cerebellar peduncles and the lower brainstem, they are typical findings in duplication patients, but usually they are not affected in deletion patients. And temporal white matter in hyperintensity, which is the last affected area in duplication patients, that temporal spreading can be seen earlier in these patients. So there are some similar findings, some differences. How are the spinal cords in those patients? In those 4 patients, all had a reduced AP diameter at the level of C2, which we can see even in brain MRI. A spinal MRI was performed only in 2 cases, and there we could not see atrophy at the lower levels and no obvious signal intensity changes. And we conclude that no such spinal cord affection in subjects with deletion as with duplication can be seen. Which factors may influence the development, type, and severity of the disease? We can see the difference between duplication and deletion. Size of the defect can have some influence, a location where the defect exactly is, but there must be also factors other than that gene itself. There can be combination with the LMNB1 gene and the other genes, and then there are so-called silencers, and we don't know very much about their role. And I give an example. This is a material which Kasar has collected from the whole world, 10 patients from 4 families, and they all had a large duplication. We could wait for those huge changes in the MR images, but it was not. Only one of those 10 had typical MRI findings and severe clinical symptoms. And those typical MRI findings were very severe. Patient was a little more than 30 years old, but if I look the changes in the brain, they were same changes which we can see our own duplication patients when they were over 70 years old. And also clinical symptoms were very severe. And what about those 9 other patients? They had totally normal brain MRI. No clinical symptoms, no clinical findings which would have been indicated ADLD. So there are many things which we don't know yet. Then we can talk. What's the benefits of MRI to ADLD patients and research? MRI is a complicated and expensive method, but we radiologists can give a specific diagnosis in most cases. Least we can have those with large duplication without any changes, and one patient with deletion with odd changes. But generally, we can say that we see if it can be ADLD, LMNB1, ADLD, or if it is something else. MRI is a very sensitive method and reveals the disease even more than 10 years before any clinical symptoms or signs. It can demonstrate the progress of the disease and which parts of the central nervous system are affected. MRI can also be used as a biomarker. All biomarkers are not biochemical. We can use MRI for that purpose. And if any therapy will be developed, MRI can be very beneficial. It helps in timing of the therapy start because it is more sensitive than clinical symptoms. And it is also possible to follow up the changes. Do the development stop or does it continue? And MRI is not only for human beings, it can also be used in animals. So that's all what I have to say.
That's about any markers of either primary or secondary inflammatory response in these patients, any gadolinium enhancement or myelin integrity studies. Do you have any data on those? I know it's hard to get these patients, hard to scan them, but any information about gadolinium enhancement or myelin integrity or other markers of secondary?
There is no gadolinium enhancement. We used that in the beginning, but then we stopped. So if there is enhancement, there is a second disease.
And these paramagnetic rings that are being investigated in multiple sclerosis, these other markers of compartmentalized inflammation, have any of those been used in these patients? Susceptibility rate?
No, I'm not sure if I understood the question.
It's a finding that has been described in multiple sclerosis, the paramagnetic rings slowly enhancing susceptibility, low signal susceptibility rings that are slowly expanding in their correlation with progressive disease.
Yes, we have histopathological examinations of the brain in 2 patients, and we can see demyelination in those white areas in our images, and we can see that demyelination is not so prominent in those rims. But we don't know what's the basic reason.
All of them have a duplication of this 9 ways.
So do you then say that this would be like an incomplete penetrant disorder?
No, it's related to the size of the duplication. So if you have a duplication of the size, you're not going to get
The duplication part I have.
Any correlation between the changes of MRI over time and the clinical progression? Because you mentioned MRI could be used as a biomarker, but have you seen that kind of parallel change between clinical decline and the
Yes.
MRI progression?
Yes, actually, those 2 graphs which I showed, the other one for MRI grades and the other one for disability scores, they show the same trend. But the changes are first seen on MRI and then in the symptoms and signs.
Variability, both MRI and clinically, how much variability onset and progression of MRI changes within a family that has the same duplication?
We had our Swedish patients, they come from two families, and the subjects, they are not patients if they have the symptoms, they are subjects. Yes, yes. And the subjects in one family, they had symptoms earlier and more severe than those in the other family. And they had about the same size of the complication.
And within the family, to all of the stuff that's happening. How much?
I think that we had quite big difference within one family. There, yes. But it is a big young. We all have different checks. And they can have effect with Spanish.
We do have another question through the chat. I don't know what it means, so I'm hoping you do. I'm sure you will. Is there any diffusion restriction or enhancement during worsening during intercurrent illnesses? Is there any diffusion restriction or enhancement during worsening through intercurrent illnesses?
I guess if there are other illnesses, does that make
We have taken diffusion images in almost all these patients, but we have stopped because we had no benefits from them. We can see diffusion disturbances, but they don't help us in understanding the disease, not make diagnosis. And if they had contrast enhancements, then they had another disease. We had two of those patients who had, for instance, shock, which we could not accept. And then we used Caroline, was shock, but it has nothing to do with it. But one disease doesn't protect against that.
Okay, I have some more questions. They're coming in fast and furious now. Thank you. I saw that general clinical disability is assessed with the EDSS scale. I'm curious if there are any other clinical scales being used to quantify ataxia or autonomic symptoms, such as ANS symptoms that are common and not part of the EDSS.
I'm sorry, I'm not a neurologist, I'm a neuroradiologist. so I know that other neurologists take some other scales first, but then use this scale for all of them.
If we can hold off on.
Not sure if I missed. Are there any studies on MR spectroscopy or advanced imaging techniques like DTI in ADLD?
Did you mention DBI? Yeah, we have DTI. I don't know any DTI study, no. And spectroscopy has been published in some individual cases. I'm not sure. No, oh, sorry. No. Now I remember. Yes, we use spectroscopy also in some, not in all patients. but we didn't find any convincing findings. But then afterward, I read an article that they had made spectroscopy in the cerebrospinal fluid. We made spectroscopy. But in the cerebrospinal fluid, and they can find high lactate concentrations. But it's very and there was no high lactate concentration